Thank you very much for all speaker for those outstanding presentation. So now we are at the session of roundtable discussion. I'm sorry to inform our audience that one of our speaker, Dr. Don Colby, unfortunately he cannot join this discussion. Anyhow, I think although we got quite a number of interesting questions, but I think the rest of the speakers should be able to help us to address this. Again, welcome to Eileen and Stefan. Yeah. Okay. So there's quite a number of interesting questions I'd like to ask either of you. And the first thing is that a lot of ongoing exciting programs or scaling up program on PrEP is mainly focusing on the MSM and transgender. So what happening with other, beyond this key population, right? People with injecting drug use, people, working on sex as sex worker, even pregnant women with, discordant partner. So could you address that, please? Eileen, maybe Eileen, start with Eileen, please.
Okay, thank you, Dr. Kia, for that question. And I will try to address that. It's an area a little bit outside of my expertise, but I do think there's opportunities to be more innovative in the arenas of people who inject drugs and women at risk for HIV, where I've seen a lot of the advances in PrEP implementation innovation. It seems to me a lot in the MSM transgender populations at risk. So I'm actually not aware of some of these newer innovative approaches, but I would turn that back to others who might have more knowledge in that arena. But I think it's an area that could be really could grow over.
Thank you. Stefan, please.
Yes, I think in Taiwan, we have always been struggling over picking up, using the limited resources, especially public resources, to help to put down the epidemic. So in Taiwan, the most increase of HIV infection, the incidents were MSM. So I think we really want, and also with the help of on-demand regimen or event-driven regimen, it surely helped to decrease the cost of PrEP program in as a national scale. However, we do see there's a need for zero-discordant couples, especially women who would like to get pregnant. So we also want to focus on that part. Also, we started to see there are young adult women and also adolescent women, and also sex workers, like female sex workers, who might have this need, even though the HIV incidence in such key populations are quite low. But we are still seeing that there's a increasing need, and also people are more willing to use that. So in the coming couple of years, I think we're also want to incorporate all other key populations in the national PrEP scheme.
Thank you very much. The other question is about the. I think probably you have addressed a bit on your talk, and the question is, what are the key success factors of community-led or key population-led services, and how we can make that sustainable? Because the issue is that when you set up a model, a pilot model, it challenges, but it's still feasible. But when you scale it, larger scale, and then how to make it sustainable. So please give us your thought about it.
Yeah, so I mean, my personal opinion with community-led, both treatment and prevention, I think there's applied lessons that can be used in many settings. There are unique issues to each community. And that is, even within Thailand, there's many different communities that might have different focuses and different efforts. But I think that the approaches can be very, very similar. And I think what's really key, at least in my experience, has been very early engagement and initiatives that are the innovations being led by the community for the community. So just thinking about all of the challenges within the community, I think that leadership really coming from within the community is best. And so having those early conversations, no matter what the community is really, I think, a key step in getting participation, but getting innovations that work in that particular community. Scale up is challenging because I think, I think there's challenges getting products or providing, oversight of product use and in different communities. I think that requires the expansion and scale up requires broader partnerships. So there might be early innovations and early pilots in communities, but when expansion comes, I think that's where the broader partnerships really have to play a role in going from community to community, but also connecting to institutions and other systems as well. So that would be my thought, but there's so many examples of successes, specifically, I think, of, really where PrEP, delivery PrEP implementation has been, the focus has been happening in Thailand, and it sounds like Vietnam as well in the community. That's a success. The demand has been a result of the community-led activities. Over.
Thank you very much. I think that a lot of critical point from that. Stefan, you have anything to add, please?
Oh yeah, I think in the presentation of Dr. Kobe's slides, he specifically mentioned that in Taiwan we don't really have that community-led strategy, which is pretty true because Truvada or PrEP, the drug, was still only available as a brand name form in Taiwan. So for the generic ones, it's only bio personal imported use. So it's quite hard for a community-led model to do prescription. And also what we try to do or to improve the delivery is that people don't need go to a bigger hospital. They'll be able to go to smaller clinic, for example, urologist clinic, and hopefully in the future, like a GPs or family doctors clinic can do the prescription. Because in Taiwan, basically, the medical access is quite convenient. So this is the other way around. Of course, we need to make sure that doctors are friendly and they're comfortable of prescribing PrEP.
Thank you.
You're welcome.
One question about, this is probably the question from the transgender individuals, that if they are taking hormone treatment, is there any potential impact on the efficacy of PrEP?
I think from the recent COI, there are 2 studies that are showing that actually it's quite safe to take PrEP while you're using hormones. First, it should be like this: like if you're taking PrEP and using hormones, the hormones will the levels of hormones will be actually stable. So you don't have to worry that as a transgender you're taking hormonal replacement therapy and this is still effective. However, the hormone might cause some level of will cause the concentration decrease in especially if I remember right would be FTC. So what's important is that for transgender women, that if you're taking a PrEP, that you should be only take it daily. And so far, it's only daily PrEP were recommended for transgender women. But these studies have been coming up. There are more and more evidence showing. So so far we probably would say that to be prudent and to be cautious, that transgender women were being only recommended using daily PrEP.
And I would echo Dr. Ku's comments. Daily oral PrEP is really the recommendation, and there's no evidence of safety impact, and that's really good news. And I think really important for transgender populations to know. It doesn't mean that there aren't ongoing research studies to evaluate hormones in different biological compartments. And those are really important for understanding these products for transgender women and transgender men. Over.
Thank you. Could you discuss a bit more on the ED approach, the event driven PrEP instead of daily PrEP? So how confident right now, and when we're rolling out, if this approach is applicable?
Yeah, I would say the evidence suggests event-driven or non-daily PrEP is a choice in some settings. Not all settings have supported this approach for a number of different reasons, but there is evidence supporting its efficacy and safety for sure. I think that there's a reason for a number of different settings not recommending non-daily or event-driven approaches. And I would say the primary challenge is around adherence to non-daily or event-driven PrEP. There are unique populations that are highly adherent and are a very good candidate population for non-daily or event-driven PrEP. But there are other populations that have more challenges with event-driven PrEP. Over.
I think in our daily practice, event-driven is actually a more preferred regimen in Taiwan, because basically people have less sex than we expected. However, it's still pretty depend on whether the individual know how to do that, because you need to really expect having sex. So sometimes people miss the precoital or postcoital dose. So for countries who started with daily PrEP only program, it's really, we really have to put emphasis on how to coach the individual to do switch. Especially when do switch, they usually make mistakes. So one key message would be that if you can do on demand, that's fine. Go back to do daily. So that will make it much safer. So people always have choices, but make sure that if people make took the wrong dosing, or they don't really understand and they fail on demand, then always go back to daily. That would be much easier for everybody.
Thank you. I think just follow up on the adherence issue. I mean, do we have any strong or good data in terms of real world effectiveness? Because like COVID vaccine, you start to see a lot of effectiveness data, which is very compelling. So the question is, after you scaling up PrEP in your target population, the question is there any data enough to convince us that this is the effectiveness and the percentage of adherence is really good?
Yeah, that's a really the real world example of the use of biomedical products. And, you know, in a trial, it's one thing, it demonstrates 92% efficacy for oral daily PrEP. And then in the real world, taking a daily medication is incredibly challenging. You know, I think that there's been a variety of different studies that have shown effectiveness in real world settings. The one thing that I think that has become very apparent is the use of PrEP really happens around risk. And so the denominator of who's at risk is a challenge to sort of follow and to use. What we've seen at Ceylon Community Clinic, for example, is that dependent on the time frame or the partnerships, there might be PrEP use, and then there might be a period of time of no risk and no PrEP use. And so the adherence kind of will vary with the risk. And I think as long as there's the support systems for adherence in those kind of waxes and wanes of risk, it can work for that individual person. But that's, I think in general, I think it's conceptually not been framed that way, that, you know, you take PrEP when you have risk and then you don't take PrEP when you don't have risk. But that is how in the real world use. I think what I've been surprised about, at least in Ceylon, is actually for those that appreciate their risk and are very on board with taking PrEP, they're highly adherent and really do take it seriously with daily reminders and self-reported adherence being very good. And so I think that what we focus on is more the counseling messages to ensure persons that come to the clinic know their risk, and if they're at risk, they know how to take the medication, and they're reminded of how important it is to adhere to it. So that's my take home. Over.
Thank you. Stefan, do you have anything to add?
I think it's in real life data. We only have smaller scaled up data from Prevenir, which is still ongoing. A lot of countries have, we can't really attribute all the decrease of new HIV incidents to PrEP implementation, though they're just telling, like UK, like in major city, also like in Australia, we also this trend. So in Asia, several countries, I think Hong Kong and Taiwan, we saw some kind of decrease with a combination of preventive strategies, not just only PrEP. So it's a little bit hard for us to say that just PrEP like doing all these contributions. So I think it will be a little bit difficult in implementation science. But you do see these trend in other Western countries like Australia and UK.
Sure, agree. Thank you. Yeah, there's one other question about STI. Do you think that along with PrEP providing, should you also provide STI prophylaxis as well, or is it worthwhile to do it? Particularly syphilis is really a major issue.
Yeah. In our clinic, we are being asked all the time about doxycycline prophylaxis for syphilis. And also we have to really warn all our individuals because doxycycline might increase the resistance to gonorrhea. So this is something that we don't really want to see. So we rather people to come back often to get tested, get shots if you're getting gonorrhea instead of just having doxycycline as prophylaxis. So far, especially in at-risk populations, we really ask people to come back more often for screening at least.
Thank you.
Yeah, and I also think like this is great in many ways. It's comprehensive sexual health treatment and prevention. So the opportunity of PrEP is actually you're doing STI screening and treatment as well. And then there have been demonstrated decreases in STIs as a result of a PrEP program that is screening and treating for STIs in a closed population. So it's a great advantage. It's one of the more comprehensive, I think, sexual health interventions we provide. And I think I have you know, I am not, I think there's a question around prophylaxis or pre-exposure prophylaxis for a number of reasons, concern for antimicrobial resistance and other issues. So I don't think it's ready for prime time, but I think it is a novel idea and there should be more research in that domain.
Right. Okay, I think it's really a pleasure, you know, joining this session with three great speakers and have a chance to discuss with Eileen and Stefan. And I also would like to thank, besides thanking all the speakers, as thank you our audience who have been coming up with a lot of interesting questions. Even right now, still some more questions coming in. But unfortunately, we have to end this session now. I'd like to also invite all the audience participants that please give us feedback so we can do better next year, and see you all next year. Thank you very much and take care. Bye now. สวัสดีครับ
สวัสดีค่ะ
Yeah, bye bye.